Hi everyone, my name is Alex Scordas and I'm from the 2016 MPH cohort. So there's only a couple of us left. So just a quick shout out to everyone who's still here. We finally made it. So I'll be presenting today on Indigenous informed approaches to evaluating harm reduction programming. So I just have some pictures here. The top left there is Niagara. So I'll just start by saying that I'm a visitor and an uninvited guest to the places that I live, work, and study. And I've thrived in these places because of the opportunities afforded to me. So I'd like to begin by respectfully acknowledging that the lands that I'm connected to through work, school, or home sit on traditional territories. So as I said there, that's Niagara Falls at the top left, and Niagara is the traditional territory of the Anishinaabe, Ojibwe, Chippewa, and Haudenosaunee peoples, and that's where I attended Brock University for nursing and where I work currently. On the top right is Hamilton, and it's on the traditional territory of the Haudenosaunee and Anishinaabe peoples. This territory is covered by the Upper Canada Treaty, and it's within the lands protected by the Dish with One Spoon Wampum Agreement, and that's where I live. And you might recognize the bottom left there, that's Mount Tomey in Victoria. So I acknowledge with respect the Lekwungen peoples on whose traditional territory the university stands, and the Songhees, Esquimalt, and Salish peoples whose historical relationships with the land continue to this day. And on the bottom right is Peterborough, and that's where I completed my final practicum placement. Peterborough sits on the traditional territory of the Mississauga Anishinaabe. I offer my gratitude to our First Nations for their care for and teachings about our earth and our relations, and may we honor those teachings. So just quickly, this is a map of central Ontario. If you're not familiar, the star at the top is Peterborough. That's where I completed my placement. On the bottom left is where I live in Hamilton, and then the bottom right is where I work in Niagara. So that's a picture of me. I'm a white settler, middle upper class, well-educated, cisgender woman, and I have no ties to Indigenous culture. So that means that I'm not really well positioned to conduct research or speak with any authority about what harm reduction should look like through an Indigenous lens. So it's my responsibility to be an effective ally to Indigenous peoples, which means that I had to complete this project mindfully, recognizing that I carry with me ingrained Eurocentric values that influence my worldview. So when possible throughout this project, I do my best to present Indigenous research and worldviews and perspectives. So for my practicum placement, I was part of a program evaluation for Peterborough Public Health harm reduction program. So they contract out this program to the Peterborough AIDS Resource Network, and the program hadn't been evaluated before. So because I conducted interviews for this evaluation, which went through their research ethics and so on, I wasn't able to use this work for my project. So instead, I developed a set of Indigenous informed recommendations for evaluating harm reduction programming, just directed by my practicum supervisor. So I'll just take a moment now to thank my practicum supervisor, Hallie, and my point person, Simone, for providing a really good learning experience, as well as the staff and faculty at UVic and the many colleagues I've encountered over the past 4 years. So I started the project by using the Indati grounded analysis framework to guide my research and recommendations. So the framework suggests mainstreaming indigeneity in policymaking and programming to minimize systemic policy bias and maximize Indigenous inclusiveness. So it recharacterizes Indigenous peoples as peoples with rights rather than minorities with problems. So that's important to note because coming from a settler viewpoint, it can be really easy to fall into the mindset of Indigenous peoples as oppressed and subjugated rather than diverse peoples with strength and resilience. So the framework also seeks to return power where it's been removed by urging people of settler ancestry to share power and create mutually beneficial partnerships with Indigenous peoples. So just a quick note on the state of research around Indigenous peoples. It's both fragmented and insufficient. Historically and even recently, research around Indigenous peoples was conducted by non-Indigenous people without consent or consultation. So some even suggest that Indigenous peoples have been researched to death. And usually this research serves government interests rather than the interests of Indigenous communities. So this project, when possible, used Indigenous research or research conducted with the principles of OCAP, so ownership, control, access, and possession in mind. So this is Ontario data here of HIV and hepatitis C among Indigenous people. So you can just take a look at some of those, but I want to be clear that these statistics demonstrate an overrepresentation of Indigenous peoples in HIV positive, Hep C positive, and injection drug use communities, but that's in the context of colonization. So indigeneity is not inherently a risk factor for bloodborne illness. A lot of the statistical literature around HIV and Hep C suggests that being Indigenous is a major risk factor for contracting these infections. So I kind of wanted to shift the discourse on that by suggesting that as colonized peoples who have faced exceptional trauma and adversity, Indigenous peoples are overrepresented in injection drug use communities. And that's kind of both reasonable and expected considering the generational circumstances. So injection drug use as a behavior is what increases the risk for contracting HIV or Hep C. Indigeneity, so being Indigenous, culture, traditions, or language, is actually a protective factor, not a risk factor. It's just an important distinction there. So one approach to reducing the risk of transmission of bloodborne illnesses is harm reduction, as we know. So harm reduction is a broad term. It refers to any approach that reduces the risks involved with a given activity, in this case, substance use. So when we think of Western or mainstream approaches to harm reduction programming, we usually think of needle exchange or needle and syringe programs that offer safer injecting, safer inhalation supplies, condoms, referrals in the naloxone, etc. Indigenous harm reduction approaches incorporate Western approaches, but at its core, Indigenous harm reduction is reducing the harms of colonization. So I think Joanna actually mentioned that earlier in her presentation. It's not simply the provision of safer supplies. And then non-Indigenous people have a role in decolonizing existing harm reduction programming, while the work of indigenizing harm reduction programming, so developing culturally safe and appropriate services, must be done by or in close consultation with local Indigenous communities. So these are the recommendations I came up with. There's just kind of a very brief summary so that I could fit them into the slide, but as a non-Indigenous person creating this project for mainly non-Indigenous people, I made it clear that these recommendations are not exhaustive and they require further consultation and review by local Indigenous communities. So it's important to start by considering how the service perpetuates racism, even unintentionally. And I suggested using a racial equity impact assessment to start this process. So part of reconciliation and decolonization is facing the uncomfortable fact that racism exists and working toward eliminating it. And then along with that, recognizing where there are imbalances in power and shifting that power to the people who are accessing the service. So most harm reduction services actually already do this quite well by offering very low barrier services and easy access. And then considering Indigenous harm reduction programming, Indigenous perspectives must be incorporated. So is there a need for more consultation and collaboration? Do local Indigenous communities even see a need for the service? So, where I was in Peterborough, local Indigenous communities weren't very well engaged with harm reduction programming, but it wasn't really clear why. So, could it have been because the programming was largely created by and for non-Indigenous people? Perhaps. So, Indigenous harm reduction also must be trauma informed. So our staff trained in these principles. Can cultural safety training be embedded within the organization? And then is the organization using research with Indigenous data sovereignty in mind? So really critically looking at what kind of research is being used to inform the program with regard to Indigenous peoples. Is it culturally appropriate? What methods were used? Were Indigenous peoples the authors of this research or working collaboratively or in partnership with non-Indigenous people? And then going further beyond the actual programming, are there Indigenous staff working in harm reduction programs or designing them or managing them? I don't suggest that those in leadership specifically seek out an Indigenous person for their staff. Like, we want to avoid tokenism, but can the organization think differently about hiring? So part of that might be engaging Indigenous peers, those who use the program and have lived or living experience with substance use. And then lastly, I suggested creating space for Indigenous culture. So it doesn't mean non-Indigenous people attempting to participate in Indigenous culture, but are there opportunities to work with local Indigenous communities to highlight culture within the organization? So I found a really interesting example from AIDS Saskatoon, where Indigenous languages were being incorporated into the programming, and it was really successful there. So we know that culture can be a protective factor when it comes to substance use. So how can it be incorporated respectfully and meaningfully within programming? So those are my recommendations, and that's all I have there. So if anyone has questions or comments, I feel like I just talked very fast.
Thank you, Alex. That was really beautifully done. Very thoughtful. Thank you so much. Are there questions for Alex?
Victoria, I think there's a question from Kayla.
Yes, thank you. Go ahead, Kayla.
Hi, Alex. That was a really great presentation. Thank you for sharing today. Our topics actually overlapped a lot in our projects, but I still found that I was learning so much from what you shared today. So thank you so much. A question that I have for you is just if in any of your work, did you come across either the challenges or the ways in which we can address how diverse Indigenous culture is and how different harm reduction can look when we talk to different nations and different communities?
Yeah, I think that's why I wanted to highlight a lot about engaging local Indigenous communities, because there's no way to create Indigenous harm reduction programming. Like that's not, we can't make anything pan-Indigenous, like it doesn't make any sense, right? So I didn't really come across any specific literature on challenges, but certainly the general understanding that I got was that it needs to be kind of local, and that's kind of how we can cater it to each specific nation or community.
Yeah, definitely. Thank you so much. I really enjoy your highlighting of how important it is to reach out to locals. Thank you.